I like to do postless distraction for my hip arthroscopy, and so we'll just imagine that the pink pad's in place here, and the patient's, where they're supposed to be, and they're in the boots, which is buttock right about here, where the the post usually goes here. So you imagine that their buttocks there or their crotch, and so to start the case, we start with distraction. And so postless technique with that pink pad in there, we have the bed in Trendelenburg, about 10 degrees. So I'll go ahead and put it there. That's kind of the main thing that makes it more difficult to manipulate the legs, but luckily you don't have to do a lot of leg manipulation when they're in Trendelenburg. That comes more when they're when the hip's reduced and we're doing the osteoplasty camera section part of it. So just lock these so it doesn't slide. Maybe. Righty-tighty, lefty-loosey, right? Okay. So basically in this position, the hip's distracted. This is when we do the labral repair part of the case, the intra-articular work, and then when we're done, basically we release the traction. So I guess let's assume that the left leg is the one being operated on. So I usually do this part at the beginning of the case. That way you guys don't have to kill yourself with the initial distraction. But basically, when they're in traction, this is the gross traction lever here. You basically pull to get their kind of hip out to length. And then once you kind of get that maximally done, then you crank this for the fine traction, usually to get the rest of the way. And we check X-ray, to make sure that we're getting appropriate distraction. Sometimes I have to break the suction seal of the hip with a spinal needle, so I usually use a 18 gauge 3.5 inch spinal needle for that, so that's not on the sterile field. So I would do a initial prep and do that, so that usually requires a first time out before we actually start the actual part of the case. But so if I'm doing that, then I'll use sterile gloves, ChloraPrep, and then the 18 gauge spinal needle to basically break the seal of the joint, which allows air to exchange between the joint and the outside environment, which allows it to come out easier. So once that's all set, we go prep real quick, drape, and then do the intra-articular work. And then when that is done, we release the traction just by undoing that, and kind of have to give it a little bit of a push to get the hip back in the joint. And so once that's done, we go back into regular position with the bed. So you just go back into regular position like I just said. Okay. So now the traction's off, and when we start the camera section, basically we do things with the hip in full extension and then in some degrees of flexion and external rotation. So usually I start with it in extension, so just down like this. And then I would just have you guys needing to unlock this boot here to rotate it. This is external rotation, neutral, and internal rotation. So when I am doing this, I'll say, can I get it in 30 degrees of external rotation, for example? So 0 degrees would be straight up like this, or neutral. So 0 degrees or neutral, you might hear me say. And then varying degrees of external rotation. So external's this way. So that would be about 15, that would be about 30. Usually I'll just tell you to rotate it, and then I'll tell you when to stop it. And when I tell you when to stop, you just lock it up again there. And then I do whatever I need to do with the leg in that position. And then, if I tell you to go back to neutral, and it's just unlock and neutral. And then internal rotation is unlock and internally rotate there. And again, I'll usually tell you when to stop. Then you lock it up. So that's kind of the easy part of that. The hard part with this bed is getting it to go up into flexion, because it can be a little bit sticky when there's a patient actually on it, and you have to also make sure that these are fully unlocked when you do that. So imagine that the patient's leg is in full extension now. So to get it up into flexion, and me or my assistant will be helping you flex the leg here, so you don't have to necessarily push it all up with yourself here. So in order to do that, you grab these two handles and slide it up forward, and I'll tell you when to stop basically. And then when you stop, you just have to lock this up again. And I should note that actually you should unlock this too before so let me start over with that. So before going up into flexion, you should unlock the rotation as well, just so the foot or ankle doesn't get twist it up in the boot. So so going up into flexion, unlock this. Obviously there's not a patient in it right now, so because as you flex up, then their foot's going to go kind of like that in the boot. I want to tell you when to stop. Lock the orange first, and then lock the rotation there. So then up in flexion, you can then manipulate the leg this way or this way. So oftentimes they'll have it abduct or frog leg out, and then so to do that, obviously it's the same thing with the rotation here. So you unlock that, and then I'll also be, me or my assistant will be, moving the leg so we're able to kind of get it where we want to. And then when we kind of get it where we want to, you just have to lock the rotation there again. So like I said, the main challenge with the bed is this can be a little sticky, and getting them to go up into flexion requires a little bit of force sometimes. And obviously, like I said, we'll do our best to help with, picking the leg up through the sterile drapes as we can. But like I said, sometimes it can be a little sticky, so that's the main issue. And then when we're all done, we'll have you unlock, and then bring it back down, and we will help with that as well. So, you guys have any questions about that? Does that make sense? I mean, it's hopefully conceptually fairly straightforward. It's just actual execution of it can be a little bit forceful, I guess. So, any questions? Looks like Brett's here.
Brett, come on in.
Do you have any comments on how this can be a little bit sticky when patients in the boots and things, like in terms of lubricating it, or?
No, it's just
making
keeping
sure
it
it's fully
broken.
unlocked.
Yeah, just make sure it's fully unlocked, and like you said, just make sure when you're doing when you are unlocking that, make sure you have this unlocked too, because you don't want to jam it up.
Yep.
Just move it in. Yeah, the easiest thing is just to make sure it's all the way back.
Yeah.
Otherwise, because like I said, it's a newer bed, so it'll be a little sticky at first.
Okay.
But that's kind of about it.
Okay. And then, as far as, there's not a lot of manipulation with this at all during the case itself. So these are this part's kind of set before we actually start the case. So the main stuff is this and this. Usually we can put these on when anesthesia is putting the patient to sleep, or as soon as they have the LMA, and whenever anesthesia is comfortable with us doing this, because we don't have to manipulate the legs too much to just get the actual boots on. So normally we like them without socks, patients without socks, to have these on contact with skin. I think that gives the best grip, and Brett can confirm that when he comes back. So the first thing you do is this middle one here. I don't know if you guys can really see that. So you take this one, you wrap it over, and you want to make sure that these are as tight as possible. So you have to kind of pull up on this while you're holding the other thing down against the skin, and you get it to Velcro on like that. Then I typically do this one next, so you kind of have to burrito this and roll it around to get it nice and tight. And then same deal, kind of hold that if you can as you're bringing that over to Velcro. And then finish up with this one. Again, making sure it's all the way tucked under, and then tight like that. So that's kind of what it should look like when you're done with that. And then as far as getting them in the boots, basically I think it's easiest to, Shelley, do you mind if I just flex your hip up? Yeah, it's easiest to do it if the hip's in some flexion, because that allows you to make sure it's fully seated. So usually up in flexion like this is best, and you want to kind of, once you get it in that position, you can lock this so it doesn't move on you. So you want to make sure that sorry, you okay, Shelley? I'm not hurting you? Okay. So you want to make sure that the heel is firmly down against the base of the boot here, and that the back of the leg, or the Achilles region, is firmly against the pad that's in the back of the boot here. So once you have that confirmed, the first strap you put on, and I'm not going to do the super tight, but the first strap you put on is the one right here, and that's the one you're going to tighten up first. So to do this, there are these two loops here, and basically you just have to kind of pull them alternating to get it to kind of seat down, and you want to pull these like as hard as you possibly can, and I'll be doing this part too before the patient's prepped and things, but So you'll see me exerting myself pretty good to get these things fully tight, because if this slips during the case, it's a big problem, because then you lose your hip distraction. You basically have to start all over again. So you do that one first, and then you can do these two. Again, kind of tightening them with the two orange things. And then this one, same thing, tightening it down. And once you have it all fully tightened with all of them, and you've pulled usually all your weight on one side, all your weight on the other, done it with all that, that's when you, and I'm not going to do it to Shelly, but that's when you unlock this again, and bring the leg back down into extension. And then you should be good to go to move on to the next step, which is the distraction part of the case, making sure we can get that before we actually prep and drape. So, any questions about that, guys? Okay, so I'll go ahead and take her out. Maybe. Okay, perfect. So Brett, I was just telling him it's best to have these on skin, correct?
Correct.
Like no socks on. What about Ted hose? That's not a problem, right?
No, I've never had a problem with Ted hose. Yeah,
Okay.
I would go skin, as close to skin as you can,
Yeah.
and then make sure that heel's sunk down in that boot.
Yep. And then wrapping Cobain around it too can make it a little bit stickier on that
You can
too.
do that as well, yep.
So I didn't do that with this one, but we can certainly do that as well. And I probably would just go ahead and do that routinely, just as another, safety point, I guess.